All right, so let us do sickle cell anemia. What is sickle cell anemia?
Is it genetic?
It is a genetic disorder. What type of genetic disorder?
Recessive.
Huh?
Is it recessive?
It is an autosomal recessive disorder, which means both parents have to be a carrier to have the child that has a disease. And even if they do have a child that has a disease, what's the chance with every pregnancy? 25% with every pregnancy. I want to be clear on that. Because when I was in school, when they said, did I tell you this? How stupid I was when I was in school? I don't know how I passed nursing school. I really don't. When they said like a 1/4 chance, I thought they meant like 1 out of 4 pregnancies. So I was like, well, why wouldn't you just keep having a baby? Like, do you know what I mean? Like if you already had a sickle cell kid, I'm like, great, then the next 3 won't have it, you know? So I just want to be clear, 25% chance in every pregnancy. If the parent has the disease, then what happens?
The child will have it?
All the kids will be carriers. Yes?
Yes.
Okay. If you have one parent that has the disease and a carrier parent, then what will happen? 50% chance with every pregnancy that the child will have it. I hate 50%. It just to me like seems like that helps me not at all. You might not. Like it's exactly equal. Do you know what I mean? So I'm like, well, that doesn't really help me. Anyhow, okay, so it is an abnormal, we know it's a genetic defect. And every genetic defect causes something to go wrong. So what goes wrong in this disease? The hemoglobin. What type of hemoglobin? S. Remember, everything in sickle cell is a S. Sickle cell anemia is an abnormality of hemoglobin. S. You diagnose it with a hemoglobin electrophoresis. Yes. Yes. Okay. So it makes an abnormality of hemoglobin S. Now in babies, you may not see signs and symptoms yet because what type of hemoglobin do babies have? F, where'd you come from? F is the fetal hemoglobin. So they have that for a while. They don't make S for a little while, right? So we may not see symptoms at birth, but because we want to catch it early, every newborn gets a newborn screen, which can screen for sickle cell. Okay. Got me?
Yeah.
Okay. So they're going to be asymptomatic for about a year unless we catch on the newborn screen, then we'll know that they have it. Yeah.
Yes.
Okay. What causes these kids to go into sickle cell crisis?
Is it the hypoxia kind of?
Hypoxia is one reason, but it almost sounds autoimmune-ish because these kids have triggers. Okay. So there are triggers, and every time they have a trigger, it's going to cause an exacerbation. Now, the hemoglobin S makes sickled cells, right? And those get stuck in different places. They clump together. They may get stuck in a teeny tiny vessel of the pinky, and they may come in with 10 out of 10 pinky pain. Okay. Well, what's the issue here?
Necrosis?
They could lose a pinky. They could lose an arm. They could lose, like, what happens if one of those sickled cells clump and get stuck in the lungs?
PE.
It looks like a PE kind of, right? Like they're going to have major issues. What happens if it gets stuck in the brain? They're going to get a stroke. Okay. So wherever it sticks, like that can cause limb threatening and life threatening issues for this kid. Do we understand that?
Yes.
But there's a crisis that's going to trigger that. Now, what would trigger your body to just all of a sudden need to make more red blood cells? Stress, infection. Yes. Okay. Now, as long as they, how do I have to do this? What else could cause them to be more likely to clump and get stuck in places?
Dehydration.
Yes. Because if they are hydrated, their vessels are nice and plump and open and everything flows through. If they're dehydrated, their blood is going to be more thick and viscous, right? And it's going to get stuck different places. Are we clear?
Yes.
What is the number one trigger for our sickle cell kids?
Infection or the stress?
Dehydration is the number one, which means in these kids, you have to keep them hydrated at all times, which is very difficult in the summer in Texas. Yes. Okay. So dehydration is number one. What do you think number two is? Infection. Because these kids are, you know, they're kids, right? They get infections a lot. Give me the other triggers. Y'all said stress. Exercise really goes more with dehydration. But if they are exercising
more up.
Yes.
Elevation.
Yeah, like elevation, you know, like the oxygen levels are lower as we, okay, so increase altitude.
Yeah.
Cold weather. Why would cold weather be a trigger? They're vasoconstricting. Yes. And then hypoxia, obviously y'all said that. Fever is another big one because when you have fever, you need more oxygen and
your body's trying to
because yes, the metabolism is higher, you're burning off more fluid, which when you have a fever, your doctor's like, drink lots of fluids. Like that's a real thing. Yes.
Yes.
Okay. So you understand when you go, you get this trigger, then you go into this sickle cell crisis, and there's 5 different kinds of sickle cell crisis. And we're going to learn them all today. Okay. But it makes the hemoglobin S abnormal. It sickles the cells, and you're either going to have a limb threatening
Or life-threatening.
or life-threatening. So it could get stuck in the lungs. It can also get stuck in the spleen. It can get stuck in the brain. So you need to be on top of these to know what type of crisis that they're having. Because when they say sickle cell crisis, I'm like, which one? Right? Because they're all going to be treated obviously
Different.
very differently. Okay.
Mm.
So what's the number one thing you want to teach this family? Avoid the triggers. Yes. So make sure they stay hydrated and get their immunizations, and they can get live because they're not immunocompromised, right? Okay. And what else you want to teach them? Just very quickly, we'll go over that one. Okay, so if they go in high elevation, they may need oxygen, or try to avoid it if you can, because honestly, that's going to be hard. Make sure you bundle them up in cold weather. You can't obviously avoid cold. Like, what are you gonna do? Not live in the winter? Like, I mean, even in Texas, it gets cold sometimes. Okay, so let's talk supplements for these kids. What are some supplements that can help their red blood cells? Ma'am. What makes healthy red blood cells? Folic acid. So all of our kids with sickle cell go on folic acid supplements daily because those help with healthy cells. Yes. Okay. Why? And this is very important. We never, ever, 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 ever give iron supplements to our sickle cell kids. How come?
They don't need it.
Why do they not need it?
They don't have deficient.
They're not deficient in iron, but don't you think these kids, like when they get sickle cell anemia, I mean, their hemoglobin's like 3, right? And they get these crises often. So if their hemoglobin's like 3 or 4, what are we going to give them? What do you give someone for a hemoglobin with 3 or 4? A blood transfusion. And they get tons of those. What's in the blood? Iron. So these kids can actually get iron toxicity. That's why we do not give iron supplements. Yes?
Yes.
Okay. They get so much iron that we sometimes have to chelate. Have you ever heard of chelation?
Yes.
With the CH. CHE. Okay. So in iron chelation, there is an antidote to iron. Do you remember what it is? You should have learned it in ATI farm. Did you say furosemide?
No.
Oh, okay. Because I was like, ma'am.
What is that word?
D. And you know what it has in it. Like, you know what the word has in it, obviously. It has to do with iron. What's the word for iron, like that you always see? Fair. So it starts with D and it's got to have fair in it. So
yeah,
you're halfway there.
I was like going. I was like, no, it has
FER.
iron in it.
Yeah, so it's got to be FER or something. So
Farinase.
deferoxamine. I'll just type. It is deferoxamine. And we're also going to give them vitamin C. Why would I do that?
Because that helps.
We're going to absorb and then pull it out with the deferoxamine. Okay, so no iron supplements for sickle cell kids. We understand?
Yes.
Okay. When they come in crisis, obviously all of their red blood cells are going to be destroyed, because when they're in crisis, that's when they really start to sickle. Okay. When your body sees a red blood cell that does not work correctly, what's it going to do to it? Lyse it. That's where they end up in the anemia portion. Do you understand?
Yes.
Hemoglobin less than 7, we're going to transfuse. Okay. We can actually do a bone marrow transplant for these kids. Okay. So they will bottom them out into like nothing, like with the bottom out the red blood cells, white blood cells, platelets. And how do we do that? No. How do we get rid of your whole bone marrow, basically? Yeah. We'll give them high dose chemo, even though this is not cancer. We'll give them high dose chemo to bottom out their bone marrow. We want like none of their bone marrow left. And then we give them a donor bone marrow that is healthy, and it will make new red blood cells that are not sickled. Do we understand?
How do they give them bone marrow?
Oh, that's a great question. So bone marrow, do you know how we take it from a donor?
Yes.
How?
You
Oh.
you take it from like their back, like their spine,
So
or not their spine,
their-
but like their lower back.
Pelvis. We're going to go into the pelvis. So you go into their hip. You go into the iliac crest of the hip. So, and you're awake. Like, this is not something I'm knocking you out for. And then they'll put some numbing cream and clean it and everything. They
looks
take this
so
big
painful.
giant needle and like put it into your bone until they feel like, and that's when you're in the bone marrow, and they're going to aspirate it this way. Then they obviously send it to the lab and like check it and all of that stuff. And then when you're ready to give it to the patient, it's given IV.
Really?
Isn't that wild?
Yeah.
That's so
How do they
crazy.
get in the bone?
It just finds its way, kind of like if you give like a stem cell transplant, right? You give it IV, like the HSCT, which by the way, you'll need to go back to adult 2 and read your HSCT notes. There's a couple things you're going to need to remember. But you give all of those IV and it will find a way.
The what notes?
For the stem cell transplants. And also for chemotherapy side effects, just so you know. Okay, so normal red blood cells, how long do they last? 120 days. How long do sickled cells last?
20.
15 to 20. Okay, so that's where the anemia comes from. Are we clear? Okay.
Yep.
Blood transfusions, bone marrow transplant. Oh, during an acute crisis, we're going to give them corticosteroids. How come?
To decrease the inflammation.
Yeah, like if there's probably going to be inflammation behind where those sickled cells are, right? It also tells your body, like, 'cause your body's going to be
Chill out.
majorly overreacting at this point because it's like something is wrong, like in all my blood cells. Yes.
Yeah.
Okay. Then we can give most of the time with these kids, they will get prophylactic antibiotics. How come?
To help them not get more triggers.
What is a trigger, right?
Infection.
Right. So if we give prophylactic antibiotics, that's going to prevent infection. Yes.
Yes.
Which then will prevent them from going into crisis. Yeah.
Yeah.
All right. We also give a drug called hydroxyurea. What is hydroxyurea?
Oh man. I asked my nurse that too.
Oh.
I just know they give it to all sickle cell kids.
Does it break down something?
Yes.
Does it break down the area? Does it break down your acid?
No. What do we want to do in these kids? Same way we did a bone marrow transplant.
You got something.
What do we want to get rid of?
The bad cells.
They're bad red blood cells, right? Okay, so hydroxyurea is basically a myelosuppressant. It shuts down their bone marrow so that we cut down on the red blood cells they're making that are sickled. And then you can get blood transfusions or packed red blood cells or whatever it is that you need. Okay, I keep seeing something out of the corner of my eye. Okay, you were talking about pain management and how important that is, right? They come in with pain 10 out of 10 almost consistently. Okay, so what kind of pain management are you anticipating giving?
Dilaudid.
Okay, so we give a lot of Dilaudid, which is very strong, and they need a PCA so they can determine how much that they get. Yes.
Yes.
Now we try to start out with like NSAIDs. That's a joke. Not if they're in crisis, right? We can also try codeine, but again, pretty weak. Most of the kids, if they're coming in and like if it's a vaso-occlusive crisis, they're going to need Dilaudid PCA. Okay. Now, what is the one opioid that we do not give to our sickle cell kids? Or if we do, it has to be very short term.
Fentanyl?
No, that's a good one.
Morphine?
Ever had fentanyl?
No.
No, you can use morphine.
No.
Opioids make me nauseous.
Centromorphine?
Huh?
Centromorphine?
It's one that causes, y'all should know this from farm. If you take it for more than 5 days, it causes a toxic metabolite.
Ooh, what's it called? What is that with again?
And
Methane.
oh, that is gas, but okay. Yeah, it's not farts. Okay. What'd you say?
Methadone?
No, that
That's
is an
where I was
opioid,
trying
but
to
it's not
go.
that one. It's the drug. I swear, I don't know. No matter what I do, nobody ever remembers this drug. Meperidine. That's when they printed on my cup because it was like so many people couldn't remember it. That's Demerol, right? It does
Yeah.
help, but you have to use it less than 5 days or it causes a toxic metabolite. Now, y'all remember that from farm. In kids, the toxic metabolite will cause seizures. So probably ought not. Yes.
Yeah.
Okay. All right. Blood transfusions. We talked about hematopoietic stem cell transplant. We talked about, yes.
Yes.
Bone marrow transplants. Y'all need to review HSCT and bone marrow transplants from adult 2 just to remember like what they do.
Okay.
Okay. So we are going to go into the different sickle cell crises. Okay. And then what we're going to do about them. All right. All right. So first one, this is the most common one. It is called a vaso-occlusive crisis. Vaso means
Vessel?
occlusive.
Block?
So we have blocked
Vessel?
a vessel. So how do you think that feels?
Very painful.
Yeah, that hurts like all holy hell. So they come in with
10
out of 10 pain, and believe them because it is painful. Okay. Severe pain. That's the biggest thing you're going to see. And then below the level that is whatever, is going to be swollen, obviously edema. Yes. And then they will get, toddlers may or may not get dactylitis. What is dactylitis?
Hands.
Look like you're doing like a velociraptor. Hands and feet.
Inflammation.
Did you say formation?
Inflammation.
Oh, I was like, yes, they grow hands and feet. Yes, it gets swollen. And that's like a precursor to their vaso-occlusive crisis. So for whatever reason, in toddlers, their hands and feet, when they start to swell, the parents are going to be like, oh, they have a vaso-occlusive crisis coming. Okay. Now I put red flags on here. And what I mean by this and red flags is these are the things like if you or get some kind of question on the exam or you're obviously in the hospital and a kid with sickle cell complains about this symptom, you're going to be like, ugh, this is bad. And then you need to know it's probably that crisis and then what to do. So the 6 Ps are the biggest things for vaso-occlusive crisis, right? Because you're going to lose a limb. Yes. So if any of the 6 Ps are present, what do?
Report to your virus.
Call the physician. Okay. So the first thing we're going to do for vaso-occlusive crisis, IV fluids, because we want to open up those vessels and allow those sickle cell to go through. Now, what a lot of nursing schools will teach in first semester is the priority is pain. It's fluids, right? Because if you do fluids, a lot of times it can relieve the pain because it will open up those vessels, right? Pain is going to be secondary. Okay. They're going to get a PCA pump with opioids. You knew that. Watch their H&H because it's going to be low. And if it goes less than 7, we're going to transfuse. They may or may not need oxygen. Only pick oxygen if they actually have a low SpO2. Right. Okay. Blood transfusions, oxygen is needed. We got this.
Got it.
Okay. So vaso-occlusive crisis. What's your big thing you need to do?
Fluids.
Yes. And monitor for
6 weeks.
6 weeks. 6 weeks. Okay. The next one is called a splenic sequestration. Remember in sickle cell, everything's an S. Vaso-occlusive crisis, splenic sequestration. Yes.
Yeah.
Government's listening to me. What is she talking about? Okay. Anyway, so what happens is these sickled cells, they are going to clump. And they usually get stuck in the splenic vein. So the blood can't go back out the spleen, right? So the spleen's just going to keep getting bigger and bigger and bigger and bigger. What's the spleen's job? Is a graveyard for red blood cells. It also has a lot of immune properties. So it helps to make new red blood cells and platelets and those kind of things, right? White blood cells, sorry. Yeah, so the spleen's going to get big and giant. Is your spleen very vascular? Don't look at my face.
Yes.
Yes. So what's going to happen if that spleen keeps getting bigger, 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 bigger?
It's gonna pop.
It's going to pop, and then
Bleed
you're going to
everywhere.
hemorrhage, and then that kid will die. So it is very, very important to note a splenic sequestration crisis. Okay, because this can happen very quickly. Where's your spleen located? She said your abdomen. Yes, that is true. Where?
To the left.
To the left. Okay. Most of the time we can't palpate it.
But if you can,
If you can palpate something over here, that's your spleen, and do not do that.
yeah.
She can be like,
It's gonna
oh,
pop.
is this a splenic cry? You know? So don't do that. All right. They will have severe anemia because you cannot recycle your red blood cells, right? So their hemoglobin is going to be super low. If any child with sickle cell disease complains of abdominal pain, that is a red flag on an exam and obviously in the hospital. Okay. Because the abdominal pain could mean that the spleen is like,
About to go.
yeah. Now, if it ruptures, they're going to have hypovolemia. So that, yeah, well, yes. Okay. Yes, you're right. You're right. You're right. She's right. She's right. All right. So your red flags here are early on abdominal pain. After it pops, they're going to go into shock, hypovolemic shock. Yes.
Yes.
Okay. So, please don't touch it. Do not palpate it. If you look at it, you see a lump there, be like, oh no. Okay. Monitor for left upper quadrant or left lower quadrant pain, because the spleen is small and that's why you can't really like palpate it and your ribs cover it. So if they're complaining of pain anywhere on that side, then oh no. You need to notify the physician immediately because there's nothing you can do to take a spleen out. Okay. All right. It will eventually lead to shock mod death. They're going to need an emergency splenectomy. Okay. And obviously they're going to need blood transfusions regardless of whether it popped or it did not pop.
Got it.
Got it. All right. Next is called an aplastic or a hyperhemolytic crisis. So hyper means high, hemo,
Blood.
lytic, kill. So it's going to kill all of your red blood cells. This is very bad. Okay. And look at what triggers it.
Folic acid.
Low folic acid. So that's another reason why we give all of our kids with sickle cell disease folic acid every day to prevent this type of crisis. It could also be a viral trigger. So we want to make sure, you know, good hand washing and yada, yada. Yes. Okay. So signs and symptoms, severe anemia. They're going to be very pale. They're going to be hypoxic and their potassium is going to be off. Now this gets a little tricky. All right. A couple of things. Why would their potassium be high? Why might they have hyperkalemia? What did we say was lysine?
Their blood cells.
Which ones?
The red.
The red blood cells. Okay. What is the predominant electrolyte intracellularly?
Potassium.
Oh.
So if you're lysine.
So if you're popping all of your red blood cells, and that's going to release potassium.
Okay.
Okay. Okay. But then what happens is we flood them with fluids. Then they will end up flushing out all of that potassium. So that's why I said, like, you got to watch potassium levels because it could go either way. Okay. All right. Red flags. If the kid is hypoxic, obviously that's a red flag. And then potassium problems are always a red flag, right? What's the first thing we do if there's a potassium problem? EKG. Okay. Because dysrhythmias are just around the corner.
Yes.
All right. So when they're in a hyperhemolytic crisis, their hemoglobin may be 4. What are you gonna do?
Transfusion.
Yeah, like lay them in bed, do not move, please, right? Put them on some oxygen. We have an SpO2 monitor, obviously. I mean, at this point, they're gonna need oxygen. Watch their H&H. We're gonna give blood transfusions, right? We're gonna give massive amounts of folic acid and then figure out what to do with their potassium, whether we need to decrease it or increase it. Do you
Got it.
understand?
Yeah.
All right. Next one is, next crisis is acute chest syndrome. Now, this is where some of those sickled cells get stuck in some of the capillaries, not the big vessels. This is not like a PE where it's stuck in the arteries or the veins. These are in the little teeny tiny capillaries, but your body still says, and brings a bunch of fluid, right? It's going to bring a bunch of fluid, which is going to fill up the alveoli. So it looks just like pneumonia. Acute chest syndrome looks exactly like it because signs and symptoms, look, chest pain, fever, chills, cough, wheezing, dyspnea, tachypnea, hypoxia. Like it's the exact same as pneumonia. Okay. If we did a chest x-ray on this kid, we would see an infiltrate because there is fluid pockets there, right? So we treat it just like a pneumonia because it could have been too that they got an infection, right? That caused it. So either way, we're going to treat it, right? Okay. So you're going to do the same thing you would for pneumonia. Sit them upright, right? IV antibiotics, SpO2, O2, watch your H&H, hydrate them, chest x-ray, blood transfusions, TCDB, which is turn, cough, do, breathe, Q2, PCA payments. Same as we would for pneumonia. Well, you're doing like pneumonia and sickle cell because obviously for pneumonia we wouldn't do PCA, but for sickle cell kids we would. Yeah. Does that make sense?
Got it.
Okay. So red flag. So if you get on an exam like, oh, a kid that has sickle cell disease starts complaining of chest pain.
Red flag.
Oh no. Yes. Okay.
Yeah.
All right. Next is a CVA, which is a, okay. This was the leading cause of death in sickle cell kids. Now they're trying to say it's infection, which doesn't really make, I think they're trying to say if it's infection, that's the trigger. That, you know, so it kind of depends on how you look at it. If you actually look at the disease process, it's CVAs. If you look at, I guess, what caused these triggers, then it would be infection. Okay. But it's not the infection that's killing the kids. You understand that? It's the okay. All right. So CVA, this is really sad in kids, obviously, and they're going to have the same signs and symptoms as adults would of a stroke, right? Which is unilateral hemaparesis, the drooling, the facial asymmetry. They're not going to use one side, right? Glasgow Coma scale may decrease. So if you have a child that's hospitalized with sickle cell anemia and they start displaying neuro changes, that's a giant red flag. Yes.
Yes.
Okay. How do we know it's a stroke?
CT.
We're gonna do a CT scan. Remember, just like we did for adults, CT scan is one of the priorities other than airway. Obviously, please pick airway first. Okay. All right. We may give TPA if we need to, or heparin. Yeah. Which is kind of scary because they already have anemia, but you know, anemia is not a bleeding thing. It's just thinner blood. Yes. Okay. And they may need surgery if the clot is severe. Okay. All right. So for all sickle cell kids, so the bottom part is like different things that you need to know about kids with sickle cell. All right. So I just did a cheat sheet on the drug therapy just to remind you. So a lot of times they're going to go on daily antibiotics prophylactic to prevent infections if they don't get a trigger, which would cause a crisis. Okay. Yes. They're taking folic acid every day. Healthy red blood cells, and it also prevents what type of crisis?
The
Aplastic or hyperhemolytic crisis. Yes. They're going to take hydroxyurea, which does what? Bone marrow suppression. They're going to take potassium. A lot of times they'll end up getting hypokalemics. We're flooding these kids with fluids constantly. Yes. They can take NSAIDs or acetaminophen at home for mild pain. Okay, but if they go into a crisis, obviously they have to go in the hospital. We're doing PCA. Okay, so what happens is this is kind of like the cheat sheet at the bottom. They get a trigger, which causes the cells to sickle, which causes autolysis. So your body is going to kill those red blood cells, and then all of those sickled cells are going to clump together, causing an occlusion, and then it deposits in different places, and that's what gives you your different crises. Does that make sense? Yeah. All right, avoid your triggers is the biggest thing you're going to teach this family, which means stay hydrated, good hand washing, vaccines. Yearly flu and pneumococcal. Remember, they can get live too because they're not immunocompromised, right? Yeah. Avoid ill contacts. And then they also have added recently to do a yearly meningococcal vaccine as well, which is wild, but that's what it is. What is priapism? I've already taught you this once. Didn't I?
Word sounds familiar, but
Probably because you were up at 2 a.m. watching the commercials that said, if this medicine gives you a prolonged erection greater than 4 hours, please contact your physician. What is a priapism?
An erection that doesn't go.
An erection that does not go away. So did you know that you can get blood that fills the penis and then the clumped cells will prevent it from going back? Well, this is a problem because the blood is just stuck down there. Okay. So we're going to apply heat, not like super hot, but like heat so that the vessels will open. We're going to give them IV fluids if we need. Like this can be an emergency. This is a big deal. And then what happens if the heat doesn't help?
You have to drain it. don't
Yes.
you? Yeah.
You'll have to stick a needle in it and
Wow. They did that on Crises.
nobody wants that to happen. There's the most cutest little bird that keeps like hopping around. And I'm sorry, I can't focus. Okay. Look, he's just so
There's
happy.
2 of them.
They're like, "Dee, dee, 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 dee." They're so tiny. Okay. Anyhow, all right. Frequent rest periods. Y'all should know this. We know we treat an infection very aggressively. Do not put cold on anything because cold does what? Vasoconstrict. I don't want to constrict around that vessel.
Yes.
You may get taught something different in your class. Your class is
Why?
wrong.
What do you mean?
All right, around the clock pain relief, very important. Remember, you have to stay ahead of the pain or we're just chasing it and it's too painful for the kid. Yeah.
Yes.
So remember, we do not do PRN pain meds for these children.
Yes.
They're either on PCA or it's scheduled. Okay. Folic acid and antibiotic prophylaxis. Y'all know that. Watch for iron toxicity. If so, we have to chelate them. And what's the drug we use to chelate?
DDA.
That is not true.
Peroxide or something.
Deferoxamine plus vitamin C. Yeah. We do need to monitor their growth because all these hospitalizations and all these crises can cause altered growth and development. So something we really need to watch. There is some research that says that penicillin daily does help decrease the risk of infections, which I agree, but it can also lead to antibiotic resistance. So you just got to kind of do with that what you will. Manage enuresis. Why would they get enuresis?
Their kidneys.
She's like, I'm just telling you that's where P comes from. Is
because like the kidneys get a lot of blood flow, so if they're sickle cell, it messes up their kidneys. I can't make it sound.
why are y'all making this a kidney problem?
It's not.
Is it a bladder problem?
I mean, I guess.
Because all the fluids we're giving. them?
Yes, you are flooding these children with fluids and bless their heart. They can't spend enough time in the bathroom and sometimes they may not make it, right? You're not like super complicated.
I was like, damn, that sounds so
So we'll
sorry.
keep it simple. So you have to give them frequent bathroom breaks. You may have to send a letter to school too that says like, hey, they need to be able to go to the bathroom as much as they want because y'all know like teachers are real mean about going to the bathroom. And then you need to manage their potassium imbalances. Now they are saying that you can quote cure sickle cell. Some schools say that with a bone marrow transplant or a stem cell transplant.
Can it?
That's a good question.
Or will it just eventually,
I think it definitely prolongs like the time that you can spend without crises.
Okay.
I don't know if I would sell it as a cure, but it does actually say cure in your book. But I'm very wary of giving patients that name unless I can 100% deliver,
Because they'll
right?
get mad at you.
Well, of course. Yeah. They will be mad when you lied to them. Yes, they will. All right. Do we understand sickle cell? Because this is a lot. Yeah. Okay. We got it now. Got it. It's going so good.